Sorry, I start a bit again. Good morning, everybody. Welcome to one more edition of the IHRS DM-DNB teaching program focusing on arrhythmias. Thanks to the elite IHRS faculty, each one from different major institutions in the country who have willingly agreed and marshaled their junior colleagues or residents to create a wonderful program for the DM-DNBs all over the country. This initiative was taken about 2 years ago under the stewardship of our president, Dr. Yash Lokhandwala, and many of the institutions very gladly volunteered, agreed to create such programs. Each time it has been a different theme, and I hope it is useful to all of you. Wide QRS tachycardia is a very relevant and sometimes a perplexing topic. You need, again, masters to explain it to you with cases, examples, some didactics. That is what Dr. Kartikeya Bhargava from Medanta, the Medicity, has done, strewn a program this time for us. And this will be very well moderated, I'm sure, by Professor Dr. Narayanan Nambudri and Dr. Venkat Nagarajan, respectively, from Trivandrum and Mumbai. I don't wish to stand much between the learning and Dr. Bhargava's team. Without much ado, I request Dr. Kartikeya to introduce his team, and we can start with the program. No further delays. Thanks. Kartikeya.
Thank you, Dr. Ashish. And first of all, apologies for the delay and inconvenience caused due to this. And I'm thankful to IHRS for giving us the opportunity to present a very interesting topic, which is not only of relevance to an electrophysiologist, but also to every cardiologist and to every physician, including physicians working in the emergency room. And so without wasting my time, I'll just introduce my fellows, current and ex-fellows, in fact. Dr. Ujjwal, who is currently with me, and Dr. Rakesh Dabba, who is in Vishakhapatnam, and Dr. Rakesh Sarkar, who is right now in Kolkata. So we will be presenting a couple of talks looking at ECGs and EPs in the wide QRS tachycardia.
Go and come when I come back and collect my bag and clear the dues also. Where can I keep the bag?
And also present
Kartikeya, just a minute. A small request to everybody attending: please go on mute. It is extremely disturbing for the program. Please go on mute. Only the moderators and the speaker, and at the most, I would remain for any comments. I request once again, please go on mute. Yeah, Kartikeya.
And yeah, looking forward to very interesting discussion with our moderators, Dr. Venkat Nagarajan and Professor Narayanan Nambudri. And I welcome you all, my seniors, my teachers, and dear colleagues. So without wasting any time, as per the agenda, I will be talking first an overview of wide QRS tachycardia. So let me just share my screen. Yeah, so the topic is wide QRS tachycardia overview and ECG differentiation. And we'll start with anatomy of the cardiac conduction system. We all know that the cardiac impulse arises in the SA node, which is in the right atrium, just at the place where the SVC enters the right atrium, and from where the impulse first depolarizes the right atrium and sequentially the left atrium, and also goes to the AV node, where after a certain amount of delay, it goes to the His bundle, which then bifurcates or sometimes trifurcates into the right bundle and the left bundle branch. And the left bundle branch then bifurcates into the anterior fascicle and the posterior fascicle, which then through a network of Purkinje fibers depolarize both the left and the right ventricles simultaneously. Now, this cardiac conduction system is extremely important because it conducts the cardiac electrical impulse very rapidly, the velocity of which is about 10 times more than what the myocytes in the atrium or ventricle can conduct. And this cardiac conduction system is in fact responsible for a normal looking narrow QRS, because both the left and the right ventricles get depolarized at nearly the same time.
Leela
Now it
just
is
hospital.
kindly
Madhana.
mute yourself, everybody. Thank you. So we know that the atria and ventricles they lie each other, but despite being very adjacent to each other, they are electrically insulated from each other, and an impulse from the atria can travel normally to the ventricles only through this specialized conduction tissue of AV node His-Purkinje system. And this tissue results in rapid conduction of electrical impulse, resulting in a normal looking narrow QRS. So just a couple of learning points that I'll talk before going to the wide QRS tachycardia. Now we know that the impulse travels in the direction away from the right shoulder and towards the ventricular apex. And the lead AVR, which is a very often a neglected lead, is special because this records the potential where its positive pole is toward the right shoulder. And since the normal cardiac impulse, supraventricular impulse, is going away from it, all the complexes in the lead AVR are negative, the P wave, the QRS, and the T wave. And that's one of the principles which are utilized in differentiation of wide QRS tachycardia. Another point is that, as I said, cardiac conduction system conducts very rapidly. And so the initial conduction is always very rapid if it is recruiting the cardiac conduction system. And so the intrinsic 110 milliseconds. As I said, the atria are activated sequentially, first the right and the left, whereas the ventricles, both left and right, with the availability of this rapidly conducting cardiac conduction system, that is the AV node His-Purkinje system, get depolarized simultaneously. All the segments of the right and the left ventricles get depolarized simultaneously. Now we know that the heart lies a little leftward, and also that the left ventricular mass is much more than the right ventricular mass, and the right ventricle lies not only to the right of the left ventricle but also anteriorly, and the left ventricle is a little posterior. And so when we look at the precordial leads, which are placed anteriorly in the anterior part of the chest, an impulse coming towards it, that is, if it is coming from the LV towards the RV, it will show a positive deflection, whereas if it is arising from the right ventricle and travels posteriorly towards the left ventricle, then it will result in a negative deflection in lead V1. So that is a very important aspect that we should remember. Also, the interventricular septum, with the position of the heart, the leads V1 and V2 span the interventricular septum. And also remember that there are certain clues, like if we have QRS complex which is negative in both AVR and AVL, the only region from where the cardiac impulse is arising could be this outflow tract region, which is again a wide region but tells you about the origin of an impulse quite better. Apart from this, their clinical history is also important. Presence of old MI, which is indicated by Q waves or persistent ST elevation, is an indicator that a wide QRS tachycardia may be a ventricular tachycardia rather than a SVT. Also, conditions like hypertrophic cardiomyopathy and presence of an accessory pathway which is manifest also sometimes gives clue to the presence of the mechanism of wide QRS tachycardia. Also remember that effect of certain drugs that are commonly used in cardiac patients like flecainide and amiodarone can result in QRS widening, and they may result in a widened QRS complex even during a supraventricular tachycardia, especially if the drugs are in the toxic range. So why is the QRS wide in bundle branch block? Now the bundle branch block occurs if there is a delay in conduction or actual block in conduction of the right or the left bundle branches, and ECG patterns occur as a result of sequential rather than the simultaneous activation of and change in the sequence of activation of different parts of the ventricles. Now, how do we define wide QRS tachycardia? Any tachycardia which by definition is a heart rate more than 100 beats per minute with a QRS duration of more than 120 milliseconds or 0.12 seconds is defined as a wide QRS tachycardia. Now, though everybody is scared of wide QRS tachycardia and diagnosis of it on the ECG, it can be simplified by just classifying into a few things that first of all, whether it is polymorphic or monomorphic, whether the tachycardia is regular or irregularly irregular. And irregularly irregular tachycardia is mostly atrial fibrillation. Whether the QRS morphology is similar or identical to that during sinus rhythm, if the ECG of sinus rhythm is available, and whether the QRS morphology, if the previous sinus rhythm ECG is not available, the QRS morphology during tachycardia resembles that of a typical right or left bundle branch block. And if these things do not help in the diagnosis, then specific features can be looked at for differentiating wide QRS tachycardia. Now, practically, one can define or classify wide QRS tachycardia into 5 different types. First of all, polymorphic VT or VF, pre-excited atrial fibrillation, monomorphic VT, SVT with bundle branch block, which could be either pre-existing during sinus rhythm or may occur only during tachycardia when we call it as an aberrancy. And finally, pre-excited SVT, including antidromic AVRT. So polymorphic VT and VF are very easy to recognize, and you don't have time to actually look at the ECG in detail because the patient will be hemodynamically unstable, and you need to defibrillate the patient immediately. Pre-excited atrial fibrillation is a tachycardia that everybody should recognize and can be easily remembered by the mnemonic fast, broad, and irregular. Now, the rhythm is quite irregular. QRS complexes are broad due to pre-excitation and activation of the one ventricle earlier than the other. And then there are complexes which are of different degrees of fusion, resulting in different amount of widening of the QRS. And once we control the pre-excited AF, you can very well see WBW pattern or pre-excitation pattern with slurring of the initial part of the QRS or the delta wave, widened QRS, and a short PR interval. Now, this tachycardia is very important to recognize because in contrast to any other tachycardia where rate control may be the initial strategy, in pre-excited atrial fibrillation, drugs which result in rate control channel blockers can be catastrophic because they can increase the conduction across the accessory pathway and lead to degeneration of the tachycardia into ventricular fibrillation, which, if not promptly shocked, can be fatal. Now, coming to regular wide QRS tachycardia, where lies the importance of analyzing the ECG in detail to differentiate whether it is VT or SVT. Now, if you look at the differential diagnosis, there are only 3: SVT with bundle branch block, of any type of SVT with the bundle branch block, which may be pre-existing or may occur only during the tachycardia, is one of the diagnoses. The other is pre-excited SVT, where the antegrade conduction occurs over an accessory pathway, resulting in early activation of one ventricle and then sequential activation of the other ventricle, resulting in widening of the QRS. But the most common cause of wide QRS tachycardia is ventricular tachycardia, where the impulse arises in one of the ventricles, and due to conduction across the myocytes, which are not very good conductors of electricity, the QRS is widened, and the sequential activation of the ventricles also contributes to widening of the QRS. Remember that this VT can also recruit the His-Purkinje system at times, and that may result in relatively narrowing of the QRS complex because of rapid conduction in the His-Purkinje system. Now, this was in 1978, the seminal paper by Hein Wellens et al., wherein they looked at about some patients with wide QRS tachycardia and gave the criteria that QRS with more than 140 left axis deviation and certain configurational characteristics of the QRS and AV dissociation were hallmarks of diagnosis of ventricular tachycardia and could be used for differentiation of SVT or VT in a wide QRS complex tachycardia. A decade later, a seminal paper by Masood Akhtar and his colleagues was actually resulted in a paradigm shift in which we view the wide QRS tachycardia. Prior to this paper, most of the times we were thinking that wide QRS tachycardia is SVT, and only if we could prove it is VT, we used to think of this as VT. Whereas this paper, which looked at 150 consecutive patients with wide QRS tachycardia, which were the mechanism of which was confirmed with an electrophysiology study, they found that 81% of these wide QRS tachycardias were VT. And if we look at the clinical history and find that there is structural heart disease or prior MI, this figure goes on to become 95 to 98%. And they also gave certain criteria of ventricular tachycardia that included AV dissociation, positive QRS concordance, axis of the QRS in the frontal plane in the northwest region, combination of left bundle branch block with right axis, and QRS duration more than 140 with RBBB and more than 160 with LBBB, and a QRS which is different during tachycardia than during baseline as diagnostic of ventricular tachycardia. So a wide QRS tachycardia, the diagnosis is very important because the significant therapeutic and prognostic implication associated with it. Drugs like adenosine and verapamil, the preferred agents for many SVTs, may prove extremely hazardous in case of VT, and long-term treatment of the two differs markedly, and VTs in general are associated with worse prognosis. Now, before we go on further, let's look at what are the QRS morphologies of typical left bundle branch block and right bundle branch block, because this should be imprinted in your mind. And when you look at any tachycardia with wide QRS and find that the QRS morphology does not fit into typical LBBB or typical RBBB, your diagnosis should go towards ventricular tachycardia. And so the typical RBBB pattern is, if you look at lead V1, the QRS is triphasic, and in V6, there is a small Q and large RS pattern and a widened S wave. Now, right bundle branch block occurs because of delay in conduction or block in conduction in the right bundle, resulting in earlier activation of the left ventricle, and the septal depolarization, which is from left to right, is preserved. And so the early part of the QRS is actually activated normally, resulting in rapid intrinsic coil deflection, but the latter half of the QRS is due to delayed activation of the right ventricle, which results in a broad latter half of the QRS in lead V1 and a broad S wave in lead V6. In contrast, in left bundle branch block, the activation of the left ventricle is delayed, and so the activation occurs first in the right ventricle and then towards the left ventricle, which is posteriorly, and so the impulse goes from the anterior part of the right ventricle towards posteriorly towards the left ventricle, resulting in a negative QRS in lead V1. And so we see a small R and S, large S pattern, or a QS, and the time to S wave nadir is less than 70 milliseconds, again because of rapid early depolarization of the right ventricle. The septal activation in left bundle branch block is reversed from normally from left to right to right to left, and this results in loss of small Q waves in lead V6 and V5 and 1 and AVL, and V6 records a wide monomorphic R with no Q wave. Now, if you look at the different ECG criteria, there are many, and one cannot, but most of the important ones include AV dissociation, QRS duration, QRS axis, the regularity of the tachycardia, and then a certain QRS morphology pattern. Now, AV dissociation is highly suggestive of VT, but cannot be recognized in clinical ECG tracing, as it is present only in 20 to 30% of the cases. And in fact, 40% of ventricular tachycardias may actually have retrograde conduction to the atria. The way we recognize this is then as ECG is by presence of independent P waves and presence of capture and fusion. Tachycardia with a positive QRS and no QRS, which may indicate capture beats, which are nothing but sinus conducted beats, and fusion beats, where the ventricular activation is occurring as a result of fusion between the ventricular tachycardia and the activation over the normal His-Purkinje system. Another example here, you don't see AV dissociation, but again a wide QRS tachycardia. But if you look at the latter half of the QRS, there are P waves which are inverted in lead 2-3 and AVF and upright in lead V1, indicating VT with 1-to-1 VA conduction. In fact, 40% of VTs may have VA conduction. QRS duration, as I said, more than 140 with RBBB and more than 160 with LBBB is suggestive of VT, but this is a soft criteria because the depend not only on whether the AV node hyperkinetic system is recruited, but where the VT is arising from. If the VT is arising close to the interventricular septum, it results in simultaneous activation of the left and the right ventricle and resulting in a relatively narrow QRS. Whereas if it is arising far from the interventricular septum, it results in sequential ventricular activation and a wider QRS. If the QRS is narrower during wide QRS tachycardia than during sinus rhythm, it can be ventricular tachycardia only and cannot be a supraventricular tachycardia as the common sense suggests. Third is QRS axis pattern. Left axis deviation with RBBB and right axis in presence of LBBB morphology is suggestive of VT, as also is northwest axis with LBBB morphology, and all these may be very helpful in diagnosis of VT. Again, this is an example of a wide QRS tachycardia where you have RBBB pattern, but left axis of the QRS in the frontal plane indicating VT, and there are other pointers like AV dissociation as marked by the arrows, which again confirm that it is VT. Now, a rhythm is the next criteria, and a grossly irregular rhythm is usually atrial fibrillation. Ventricular tachycardias are considered to be usually regular, but sometimes they can be slightly irregular, especially during the onset of the tachycardia. Paroxysmal supraventricular tachycardias, in contrast, are usually not regular. So this is an example with a wide QRS tachycardia with typical LBBB morphology and very irregular RR intervals suggesting atrial fibrillation with left bundle branch block. This is an example of pre-excited atrial fibrillation. Again, wide QRS complexes, very rapid ventricular rate, and irregular rhythm, all diagnosing pre-excited AF. Finally, QRS morphology, looking at the pre-existing similar ECG during sinus rhythm. Concordance of QRS complexes in the precordial leads is highly suggestive of VT. And you see these two examples. In panel A, you have negative precordial concordance suggesting a VT arising from the apical region. And in the other panel, you see a wide QRS tachycardia with all positive QRS in V1 to V6, indicating again VT, which is arising from the posterior left ventricular wall. Having said this, now it is almost impossible just looking at the ECG QRS configurations to differentiate VT from pre-excitation. But we know that pre-excitation or earlier activation of the ventricle due to presence of an accessory pathway has specific patterns because the accessory pathways lie in specific locations, and that sometimes can help in differentiating pre-excitation versus VT. However, the morphology criteria, one cannot differentiate VT from pre-excited QRS complexes. Finally, QRS complexes, we know the morphological patterns during SVT with RBBB, and if the R wave is monophasic or biphasic in V1 and only a QS complex or small r and large S complex in V6 during a wide QRS tachycardia with RBBB pattern suggests VT. In LBBB pattern, again, absence of R wave or a very large R wave in V1 and time from the onset of QRS to the nadir of S wave more than 70 milliseconds suggests VT, and presence of a large Q wave, pathological Q wave in V6 also suggests that it is VT. Now, this is an example where a wide QRS tachycardia with typical LBBB narrows down with the same cycle length, and it suggests, since the morphology is that of typical LBBB, that it is SVT. There are many algorithms that have been described to differentiate VT and SVT, but as I would say, the learning the underlying principles behind these algorithms are more easier to apply in clinical practice than remembering these algorithms, which is almost impossible. Brugada algorithm is one algorithm which has a sensitivity of about 98% for diagnosis of VT and looks at AV dissociation, delayed early part of the QRS activation. Differentiate between SVT and VT. Another one is Griffith's criteria, where wide QRS tachycardia is diagnosed as VT unless it satisfies criteria for typical LVBP. And then there are other criteria using lead AVR, again based on the same principle that the supraventricular impulse typically travels away from the positive electrode of lead AVR, and hence a VT will have a positive deflection in lead AVR initially, especially in the initial part of the QRS complex. So with this, I'll end, and we'll be happy to discuss these principles with the moderator, Dr. Venkat. Thank you very much.
Thanks, Karthikeya. I think all of you who listened carefully to this presentation would have picked up a lot of points. Venkat, the floor is yours to generate a discussion for next 10 minutes. We will not compromise on the discussion because of the late start. I think we have time on this. Venkat.
Thanks, Dr. Nabar, and excellent presentation by Dr. Bhargava. So I just have a couple of sort of comments for all our trainees that when you are approaching wide, broad, complex sort of tachycardias, they are all should be treated as VTs unless you can show or prove that it's an SVT. So that's an important thing. And secondly, I would like to say that you need to treat the patient, obviously, not the ECG. So that is the second thing. I would like to ask Dr. Bhargava just to, in his talk, just to add a few words about sort of clues on the ECG for the epicardial origin. So this may be important when you are planning for an ablation procedure. So, obviously, when you are looking at the ECGs, so one, the sort of important thing is to diagnose. Secondly, to treat the patient, and then going forward. So I think it is important in some ways how you treat the patient. So we know that fascicular VTs with structurally normal hearts, you can give them intravenous verapamil, but the same can be disastrous if they have underlying ischemic heart disease or if they have structural problems. So that way, I think the ECG differentiation is very, very important. And also going forward, when you are treating the patients, making decisions as to who should be referred for a ventricular tachycardia ablation and who needs a defibrillator. Again, the ECGs, when we are talking about structurally normal hearts, ECGs that are easily amenable by ablation, where a defibrillator may not be sort of indicated, is important. And similarly, when you're treating with non-ischemic cardiomyopathies and you're planning for an ablation procedure, and there, I think the ECG gives clues as to where the origin of this VT is, and if it's epicardial, then you would need to, when you're going for the ablation procedure, you would need to plan for an epicardial approach. So I would like to ask Dr. Bhargava if he would like to add a couple of points about the clues wherein you can be confident or where it is suggestive that the origin of the VT could be in the epicardial region. Would you like to add, Dr. Bhargava?
Yeah, thank you, Dr. Venkat. So a couple of comments. One is one should understand what do we mean by structurally normal heart. Till maybe a decade ago, a negative stress test and a normal echo was considered sufficient for defining a structurally normal heart. However, now we know that there are many conditions, especially which cause inflammation and cause inflammatory myocarditis, especially granulomatous myocarditis, where the echo may be entirely normal, the coronary angiogram may be normal, but we can find a scar in the myocardium during a cardiac MRI, contrast an MRI or a cardiac PET scan. And for all these wide QRS tachycardia, which look like ventricular tachycardia, but do not fit into a pattern which has been described as idiopathic ventricular tachycardia, we should always do a cardiac MRI and look for cardiac sarcoidosis and tuberculosis, because these are specific diseases which can be treated specifically and may change the course of the disease. itself. So that is one point. Second is regarding the epicardial. Now, there are certain accessory pathways that can be epicardial and may indicate to you the presence of coronary sinus diverticulum, which may help you in planning your procedure, electrophysiology procedure. And this is indicated by, if it is a manifest accessory pathway, a deep negative initial QRS, initial part of the QRS in lead 2, which may suggest that there is an epicardial accessory pathway and may prompt you in the presence of an apostoseptal pathway to look for coronary sinus angiogram and look for a coronary sinus diverticulum. In ventricular tachycardia, again, normally we know that the activation in the myocardium occurs from endocardial to epicardial. If it is epicardial to endocardial, the initial deflection becomes quite delayed. And so there are multiple criteria that have been defined, which may tell you that it is an epicardial ventricular tachycardia. But in general principle, delayed initial activation, which looks like a delta-like pattern in the ECG, suggests to you that it may be an epicardial pattern. And then there are certain substrates where, for example, the underlying clinical disease like ARVC, where we know that majority of the ventricular tachycardias may have an epicardial origin, or examples like idiopathic dilated cardiomyopathy, where about again 50-60% of the VTs may actually be epicardial. So those things, those clues also help you in planning your electrophysiology.
Yeah, Karthik, just a small comment on the etiological aspect is to find out if there are leads which show QR pattern. The leads which show a QR pattern and not necessarily a QS pattern indicate a scar in that region. So for example, in a VT of a right bundle branch block morphology, you have a QR pattern in V1, V2, V3, you can easily say that there is a scar in the antral wall, probably from an old antral wall infarction. And you can have some etiological diagnosis even when the VT is on. Of course, in sinus rhythm, you can certainly make a etiological diagnosis better. I think if Karthikeya, we might be a little.
That's a very excellent point. In fact, not often recognized that during sinus rhythm, we know that Q waves indicate the presence of a scar due to a prior myocardial infarction. But that also holds true during the ECG of a ventricular tachycardia. Large Q waves during VT suggest that there is an underlying scar, and the not only that the etiology may be ischemic heart disease, but also the underlying infarct in that territory where there are Q waves, the leads overlying that show Q waves.
Yeah.
That note,
Suchit is asking if you can get a VT during monomorphic VT during inflammation at during scar.
Yes. So I request everybody to please put on mute.
1 second, Karthik, I will do that systematically. Namitab, please put everybody on mute and the speakers only unmute. Dr. Sandeepan Datta, you are a constant source of disturbance. I have even messaged you privately, but it doesn't seem to work. Namitab, are you there? Yeah. So Karthik, please unmute, and Venkat, you can unmute yourself.
Yeah, sure.
Yeah. Yes. So what we were discussing.
Yeah, absolutely.
It's a real disturbance. The inflammation and scar.
Yes. Yes. So we know that inflammatory myocarditis, especially sarcoidosis and tuberculosis, and there are many more in other parts of the world, which can cause monomorphic VT. And this is very important to recognize. Now, the VT, monomorphic VT may occur because of two reasons. One may be the acute inflammation itself, and which can be better treated with anti-inflammatory drugs like steroids, and in combination with antiarrhythmic drugs, and can also occur due to scar which develops as an end result of this inflammation. and a particular patient may have VTs because of either of these or both of these reasons. And so it is important to understand whether a VT relapse occurring in a patient who has a known inflammatory heart disease is occurring because of acute inflammation or presence of old scar, because that may change your plan of management. If it is inflammatory, escalating the steroid dose or adding other immunotherapeutic agents may be better off rather than increasing the antiarrhythmic drugs. Whereas, and RF ablation is not a good idea at this point of time. Whereas if the VT is because of the presence of scar, then RF ablation or escalating the antiarrhythmic drugs and maybe stellate ganglion blockade may be much better options than increasing the dose of steroids.
Sure. Karthik, if you agree, let's move on to your quick presentations and then Venkat can again moderate both the next cases.
I'll just add one statement,
sure.
Ashish. I just saw a question from one of the participants saying that how to differentiate a pre-excitated tachycardia from VT. So just at a quick initial look, if you see an intrinsicoid negative deflection in any of the precordial leads from V4 to V5 with a QR pattern or a Q waves, that virtually rules out a pre-excitated tachycardia. That is more in favor of a VT. That's what I would just add. A quick look. If you see that there is an intrinsicoid negative deflection in any of the precordial leads, then that goes against the precordial sort of pre-excited tachycardias and more likely to be VT. Sorry, you can carry on, Dr. Karthik.
Okay. Yes, so I'll invite Dr. Ujjwal to present his two cases of ECGs and request Dr. Venkat to moderate those.
Good morning, everyone. I'm Dr. Ujjwal. I'm a fellow in electrophysiology at Medanta. I'm working with Dr. Karthike. I'll be presenting a few cases of ECGs having wide QRS tachycardia. So my first case is, he's a young male in his early 20s who was completely healthy and did not have any previous cardiac history. He's quite athletic, working at a police department, and he presents suddenly with a history of a syncope while he was running, and he had shown up to a nearby hospital where an ECG was done. So here we can see the ECG. It is a tachycardia. So on a closer look, we see that the rate is around 220 and the rhythm appears to be regular. So the QRS appears widest in lead 2, that is, I've highlighted it here. That is almost around 4 small boxes, around 160 milliseconds. And the morphology is of LVV type, but it is of atypical LVV morphology, where we can see that there is no broad slurred R waves in one AVL. But there are no septal Q waves in V5, V6. And apart from that, if we see the QRS axis here, it is around plus 60 to plus 70 degree AVL is equiphasic, and then lead 2 is positive. And we are not able to clearly make out any P waves as such in this, so very difficult to comment upon the AV dissociation. So on a closer look here at the AVR, we can see that the initial part of the AVR, that is heavy, it appears quite prolonged, and the terminal part of the AVR, it is quite smooth. And one of the more interesting part of this ECG, if you look at the standardization over here, it is having 2 standardizations. The first part of the limb leads is normal, and the second one of the chest leads from V1 to V6, that shows 1/4 of the standardization. So this is quite a unique thing which I've seen in this ECG. So after this, the patient was cardioverted over there, and this was his ECG following cardioversion, where we can see it's a normal sinus rhythm having a quite large P waves, tall P waves showing a right atrial abnormality, and we have inverted T waves in lead V1, V2, and V3. So all this leads to our suspicion of ARVD, where the VT was having LVV morphology, and when the patient was cardioverted in sinus rhythm, it shows T inversions in leads V1, V2, and V3. On careful examination, I'll just zoom in the lead 2, where we can see some amount of terminal deflection notches in terminal part of the QRS in lead 2. So it is not actually an epsilon wave, but some sort of a notches are seen in the terminal part of the QRS over here. So we went on to the next diagnosis of echo, and which showed a normal RV function with normal RV parameters, TAPS of 2.1. So that did not help us much. So we went on to get an MRI done, which showed a RV global hypokinesia with an RV ejection fraction of 39%, and RV endosteric volume to body surface area ratio of around 107 milliliter per meter square, which would satisfy the minor criteria of having between 105 to 110. And it also showed some mild circulations along the RV free wall in mid to apical region. So it satisfied the two major criteria of ARVD, and hence this patient was turned out to be having ARVD. So my second case here is we have a middle-aged gentleman who is around 51 years age. He's a known case of valvular heart disease. He had a past history of AVR in 1998 and a BMV in 2018.
Ujjwal, maybe a quick comment from Dr. Nagarajan on the first case, if he has.
Oh, yes, yes.
Yes. I think it's a very good case. So since we are talking about differentiation based on the ECG, I would like to talk a few more. I would like you, or I can say a few more points about the 12-lead ECG itself. So just looking at this ECG in a young man, do we say that this is pre-excited? As we just said, if you see the Q waves or QR waves in precordial leads, that virtually excludes that. Now, what is pointing towards VT in this case? If you watch closely, the initial deflection, it's always when you're talking about VT, this is originating in the myocardium. So the initial deflections are very slow. So if you see AVR, if you see the initial deflection bit, there is a notch.
Ujjwal,
so
can you point at what Dr. Nagarajan is saying on the screen?
So if you see the initial deflection, and if the initial deflections are slightly slower than the terminal deflections, that always points towards VT. So here again, we have heard the talk from Dr. Bhargava, AVR is negative, and there is the sort of slurring of the downstroke of the AVR, and that again points clearly towards that this is VT and not SVT. Now, you said you can't see the P waves very clearly. If you just look at AVL, I'm not sure that you can see sort of P waves there, but it's not a proper, if you track it, it's not a proper one-to-one sort of AV association. So there is some amount of AV dissociation as well. So based on all these things and the QRS duration, I think I can't exactly measure, but if you look at V6, this clearly looks quite broad complex, more than 160 milliseconds it appears to be. So I think based on these things, clearly we know that this is VT, and accordingly the patient was hemodynamically unstable, I guess, and hence was cardioverted. So again, as you have presented in the echo, there are abnormalities in his resting ECG. There are sort of abnormalities in the precordial lead. So that is very important for his long-term follow-up. So he's a healthy man with a normal LV function, but again, he's got abnormal RV function, and this man needs to be followed up long-term, and he may run into more problems. So yes, we will move on to the second case.
Thank you, sir. Thank you for the knowledge. Here's the second case. We have a middle-aged gentleman around 51 years of age. He's a case of valvular heart disease, having a AVR in 1998 and a BMB in 2018. Now he presented to us with class 4 NYHA class 4 dyspnea. His echo at that time showed a severe mitral stenosis with a dilated LA and the RA, and his LV ejection fraction was around 50%. So he underwent an MVR, and we were called up on his third post-op day, and this was his ECG. So here we can see this ECG here. It's again a tachycardia where the rate is around 160 beats per minute. But on a closer look, we can see here it is having an irregular rhythm. So here I have highlighted it. So this clearly shows it's an irregular rhythm. So, and apart from that, it is having a typical LVV morphology. Here we can see there are broad notch slurred R waves in one AVL, and in V1 and V2, we can see the QRS is wide, around 120 milliseconds with a notched S wave. And there are absent septal Q waves in one V5, V6, and both in one AVL. So, and apart from that, there is a left axis deviation in this patient, and also there are no Q waves seen properly in the rhythm strip. And this patient was also defibrillated, and following that, this was his normal sinus rhythm. Here also we can see the baseline rhythm is also again, he's having LVVV with left axis deviation. So the morphology is quite similar. what he was having when he was in tachycardia. So therefore, this patient was having atrial fibrillation with left bundle branch block. So to summarize, I presented two cases. First case was an ARVD with VT LVB atypical morphology with sinus rhythm having T inversions in V1 to V3 with notching and terminal QRS, which was confirmed with the help of an MRI. And my second case was a AF with typical LVB in a valvular heart disease patient post valvular replacements. And there were similar changes what was seen in the tachycardia ECG, and it was same changes were seen LVB in the sinus rhythm ECG. So thank you, sir.
Yeah, just I'll just make a couple of comments here.
Yes, sir.
On top of what you said. You can see that in this sort of VT, there is a changing morphology as well. The morphology is not constant, it's irregularly irregular. When we talk that VT is irregularly irregular, if there is a more than 40 millisecond difference beat to beat, that is
you mean wide QRS tachycardia, right?
Yes, wide QRS tachycardia. If there is more than 40 millisecond beat to beat difference, it makes it less likely for it to be sort of monomorphic, organized VT. So, but in this case, as you said, that it is quite irregularly irregular, changing. There is a slight change in the QRS morphology as well, and resting bundle branch block, and given in a patient with a left atrial dilatation mitral valve replacement. So AF with bundle branch block fits sort of very well.
Which was by far the most impressive thing for me was the rapid intrinsic arc deflection in V1,
Yes.
V2. Yes. Okay. Are you done with?
Yes, sir.
We can have the next presentation. Dr. Abba, you can stop sharing the screen.
Yes, sir. I'll just do that, sir.
Very illustrative cases.
Thank you, sir.
Usually you can stop share.
Yes, sir. I'll just.
This is
When you take your mouse to the top, you will see a stop share, red colored.
Yes, sir.
Yeah.
Thank you, sir.
okay, Rakesh.
Am I visible, sir?
Yes,
Yes.
we enjoyed hearing you in the digital IHRS 2021.
Sir,
Come once again. Yeah.
good morning, sir. Good morning, one and all. This is Dr. Rakesh. Thank you, Karthikeya sir, and IHRS team for giving me this opportunity to present in this meeting. So today I'm going to present two cases who presented to ER with history of palpitations and ECG showing white QRS tachycardia. So my first case is an 18-year-old boy who presented with history of palpitations and with no comorbidities. ECG during palpitations is showing white QRS tachycardia, and echo is done, which is normal, and cardiac MRI, which is done at a later date, is also normal. So his ECG at baseline is showing normal sinus rhythm with 1:1 AV conduction and a narrow QRS and normal QRS axis and normal PR intervals. And this is ECG during palpitations, which is showing a wide QRS regular tachycardia with right bundle branch block morphology with a ventricular rate of 125 beats per minute. And on further evaluation of the ECG is showing QS complexes in lead 1, which suggests that the ventricular activation is occurring from the left to right, and at the same time the QRS complexes in lead 2, 3, and AVF are positive, suggesting that the ventricular activation is occurring from above downwards, that is the outflow tract region. It's confirming that the QRS complexes in lead AVL and AVR is negative. Even though here the lead AVR is showing a positive QRS complex, here the if you clearly see it is minus AVR, which is the previous representation of the standard limb leads. So this is, and on further delineation of the ECG, it is showing evidence of AV dissociation with evidence of P waves. Am I visible here? There are P waves in this ECG, which is suggestive of AV dissociation, and there are occasionally narrow QRS complexes on the ECG, suggestive of fusion beats. So this is a wide QRS complex tachycardia with AV dissociation, so suggestive of ventricular tachycardia. So to localize the ECG tachycardia further, it is showing predominantly positive precordial concordance, which is suggestive that it is originating from the base of the left ventricle. And at the same time, because it is having inferior axis, it is suggestive that it is originating from the outflow tract. And because it is predominantly positive right bundle branch block morphology, it is originating from the posterior aspect of the left ventricle. So taking all these points into consideration, the most probable location of the origin of the ventricular tachycardia is lateral mitral annulus. So we have taken up him for EP study, and this is the EP tracing showing standard surface leads 1, 2, and V1, and catheter positions in his location, coronary sinus, and catheter in the RV apex, and catheter in the left ventricular cavity. So in this, the first thing which is seen is a negative HV interval and with AV dissociation, which is seen by varying VA intervals while during the conducted beats. And there is also sequential activation of the ventricles, which is evidenced by earliest ventricular activation in the left ablation catheter, followed by a right ventricular apex catheter. So this is suggestive that the focus of tachycardia is in the left ventricle, probably in the base of the left ventricle. So, hello?
Yes, audible.
Yeah.
Shall I continue, sir? The next case?
Yeah, maybe Karthik can give some comments and Venkat can also add.
Yeah, so we have wide QRS tachycardia with precordial concordance, positive precordial concordance.
Maybe show the ECG, Rakesh.
And inferior axis, and with indicators of AV dissociation. So clearly a ventricular tachycardia, and the QRS morphology is suggesting origin from the lateral mitral annulus of the left ventricle. And if you look at the intracardiac electrograms, the very interesting thing that we always talk about now here, during an electrophysiology study, wherever you may place your catheter, if the QRS is narrow and has a normal ventricular activation sequence, the ventricular electrogram in any catheter will be occurring nearly at the same time. However, here you see that a catheter placed in the left ventricular lateral region, lateral mitral annular region, shows a very early activation, whereas the activation in the right ventricular apex is quite delayed. And this is basically suggesting a sequential activation depicted on the surface ECG by a widened QRS complex. Now, the other point is that whether there is AV dissociation or not, you clearly see that there are 6 QRS complexes, but 3 atrial signals. And so one may
point out, Rakesh.
Yes. So one may think that there is VA conduction in the pattern of 2 to 1. However, if you have to have VA conduction, the RR will be regular. Even the PP interval or atrial AA signal should also be regular. But if you look at the tracing, you find that the apparent V to A interval during the first beat is much longer than V to A interval in the last beat. And so this is basically totally independent atrial activity occurring independently of the ventricular activity, indicating AV dissociation. Also, you can see that in the His bundle tracing, you see a sharp deflection, which indicates a buried His bundle electrogram in the QRS complex. And the conduction is occurring from V to His, but there is a block from His to A, indicating AV node as the level of block in this tracing.
Sure.
Karthikeya, in case if you can see that ablation distal and the QRS in, local electrograms in CS12 to 78, they are far apart, no? And CS12 is late after the QRS onset. Where is ablation catheter? Is it at basal LV or somewhere else?
It is in the lateral mitral annulus region. The CS was not deep inside because could not be go deep inside. So that's why it's not showing very late, very early activation CS12. But the ablation catheter was in the mitral annular region at the earliest active.
Yeah, I think that is a good comment from Dr. Narayan to explain to how a electrophysiologist's mind works with those limited catheters to say what is early, what is really early, and how you relatively decide what is early with respect to the other electrograms. Great, great discussion. Sure. Rakesh, what are the different sites from where you get idiopathic LV tachycardia? If you can just enumerate for the sake of, and before you move to the next case.
Sir, idiopathic LV tachycardia, the predominant site is the outflow tract region, sir. And out of the outflow tract region, right ventricular outflow tract is the most common site, followed by the left ventricular outflow tract. And in the
different sites in the sure.
In the left ventricular outflow tract, the sites can be in the aortic cusps from the most commonly is from the junction of the right and the left coronary sinus, and then in the aortomitral continuity, and then followed by the mitral annulus. And it can also in the left ventricle, the idiopathic VT can also arise from the papillary muscles also.
Right. So outflow tract and then the fascicular VT can have papillary. One more site in the outflow tract can be obviously epicardial. Sure. Please move on to your next case.
So my second case is a 50-year-old gentleman who presented with history of episodic palpitations with a documented wide QRS tachycardia. So he's an hypertensive on losartan and amlodipine, and his ECG at baseline is showing sinus rhythm with 1:1 AV conduction and NARA QRS complexes. And his echo on evaluation is normal, showing normal LV function with the concentric left ventricular hypertrophy. So his ECG during tachycardia is a wide complex tachycardia, which is regular with a ventricular rate of 180 beats per minute and with a normal QRS axis. So the left bundle branch block morphology can be seen by prominent R waves in lead 1 and V5 and V6 and QS complexes in the lead V1. So our idea now is to differentiate between whether it is an SVT with aberrancy or a ventricular tachycardia. So some of the features which were described by Karthikeya sir, I want to just enumerate. So absence of the initial R wave in lead V1 or V2, and if it is there, the initial R wave should be less than 30 milliseconds in duration, and there is a sharp downstroke of the QS complex in lead V1, and there is an absent Q wave in lead V6, which is again suggestive of true left bundle branch block morphology. And the R wave intrinsicoid deflection in V6 is more than is roughly here it is around 80 milliseconds in duration. So, and there are no discernible P waves. All these features are suggestive of an SVT with left bundle branch block aberrancy. And so he's taken up for EP study with a baseline. The baseline EP study showed normal AH and HV intervals and a narrow QRS. On atrial pacing initiated a left bundle branch block aberrancy with normal HV interval during the atrial pacing, ruling out an associated atriofascicular pathway. And tachycardia induced during atrial pacing, which is of left bundle branch block morphology, and with a positive HV interval and with simultaneous activation of the ventricles and the atrium and a narrow and short VA interval, which is suggestive of an AVNRT with left bundle branch block aberrancy. So this is further confirmed by an effect of a spontaneous PVC. This is the fourth beat in this tracing is a spontaneous PVC. Prior to that spontaneous PVC, the 3 beats were of wide complex, which is left bundle branch block morphology. And just after the spontaneous PVC, the next 3 beats are narrow QRS complexes with a positive HV interval and simultaneous activation of the ventricles and the atrium. which is suggesting that this is the the wide QRS complex tachycardia is nothing but an AVNRT with left bundle branch block aberrancy. And this is an ECG showing the same thing, that the conversion of a wide complex tachycardia into a narrow complex tachycardia after because of the spontaneous PVC.
Rakesh, if you go back those 2 slides, I would like to ask Karthikeya to explain a few things. One more fact. Yeah, no, the tachycardia.
Sir.
Karthikeya, can you deliberate a bit on this as to when would your diagnosis be a MAHEM, when will your diagnosis be a VT, and why is this an AVNRT?
Yeah, so for any wide QRS complex, there are 3 possibilities. One is an aberrant conduction or bundle branch block. The other is a pre-excitation, and third is a ventricular tachycardia. Now, for pre-excitation and ventricular tachycardia, your HV interval has to be less than normal or maybe negative also. If the HV is positive and maybe same or maybe slightly more than during sinus rhythm, this has to be SVT with aberrancy or bundle branch block. And so here we see that during atrial pacing, the HV remains positive and same as sinus rhythm, but the QRS morphology changes to LBBB type, indicating that at faster rates, there is left bundle branch block aberrancy. And same thing is seen during tachycardia also, that you have an LBBB morphology. The QRS morphology is identical to that during the clinical tachycardia, but the HV remains positive and same as during sinus rhythm. So this wide QRS is because of an SVT and with aberrancy, and the atrial activation, which is occurring nearly simultaneous with ventricular activation with a short septal VA, indicates that this is SVT due to AVNRT occurring with left bundle branch block aberrancy. Now, this is further confirmed with the next slide, a spontaneous PVC, which results in narrowing down the QRS complex with same HV interval and same cycle length, indicating that the left bundle branch block was actually functional and not pathological. And in the same tachycardia that is continuing, the PVC just peels down the refractoriness in the left bundle because it blocks the left bundle, and so the left bundle gets more time to get depolarized during the subsequent beat, resulting in conduction through the left bundle also, and eliminating the aberrancy during the wide QRS tachycardia.
Okay, Rakesh, please move.
So after confirming that the tachycardia is a typical AVNRT, so our radio frequency ablation was done in the slow pathway region, which is evidenced by origin of the junctional beats. And even here, the last 2 junctional beats conducted with left bundle branch block aberrancy, which is evidenced by positive HV interval, and which is same compared to the while do the narrow QRS. And so the final diagnosis in our case is case 1, which idiopathic ventricular tachycardia originating from the lateral mitral annulus, that is right bundle branch block type with inferior axis, positive precordial concordance with VA dissociation. And our case 2 was typical slow fast atrioventricular nodal reentry tachycardia with left bundle branch block aberrancy.
I'll just make one comment, Dr. Rakesh, is that the sort of tachycardia that you induced during EP study, I think it would be nice, but maybe you don't have, nice to see the 12 lead of that, because you can see a lot of tachycardias when you go into the EP study. So, I mean, also we need to relate that this is the clinical tachycardia that the patient has presented with. I'm sure that it is identical to the tachycardia that the patient has presented with. So that is important for people doing EP studies and ablation, that sometimes you may have multiple tachycardias induced during the sort of EP study and coincidental AVNRTs. But also we need to always compare what is the clinical ECG of the tachycardia that the patient has presented and what we are actually ablating. Yeah. So
okay.
The only comment.
Thank you.
I think the next 2 presentations from Dr. Bhargava's group will be in relation to the EP. So we have some at least 80 to 90 postgraduates and early career cardiologists attending. I would request you that the next segment is going to be more informative or as informative as we have had up till now. So please be there to listen to them. I think Rakesh, can we wind here and move on to Dr. Sarkar?
Yes, sir.
Okay. You can stop sharing your screen.
Stop, sir. Didn't I, sir?
Yes. Yeah, Dr. Sarkar.
Yeah, sir. Is my slide visible, sir?
Not yet.
Is it now visible, sir?
Yes.
Yes.
Shall I start, sir?
Yes, sure.
So, good morning, my respected teachers and colleagues. At the outset, I would like to thank IHRS and Dr. Karthikeya sir for giving me the opportunity to be the part of the session. I'll present few cases on white QRS tachycardia with negative HB interval. So my first case is a 40-year-old boy who presented with frequent complaint of episodic palpitation requiring sometimes medical therapy for termination. And most of the time it remains hemodynamically stable outside the hospital. The baseline ECG is showing normal sinus rhythm with narrow QRS, which is illustrated on the right side of the slide, and echocardiography is essentially normal. So we took the patient for EP study, and baseline EP study showed normal baseline intervals like AH and HB intervals, and normal AV conduction, normal 1:1 AV conduction with the concentric VA conduction during the V pacing. So we went ahead with the initiation of the induction of the tachycardia because we didn't have the clinical tachycardia ECG with us. So on atrial pacing at 280 millisecond cycle length with atrial burst pacing, we were able to induce the RBB morphology regular tachycardia. You can see here the P waves is appearing at the sometimes at the later part of the QRS as inverted, especially in V1 and lead 2 and lead 3. Although it's not very much well appreciable, but I presume that there is some inverted POF which is appearing as VA dissociation, and RBB is having northwest axis with small r with big S in V5 and V6. So with that given ECG, we presume that the current tachycardia is probably attributable to ventricular tachycardia, possibly from left posterior fascicle. So when we try to look at the intracardiac electrogram, we can see here clearly the negative HP interval, which is coming after the onset of the QRS and with 1:1 AV relationship with concentric atrial activation pattern, and you can see that the tachycardia cycle length is 340 millisecond. So we went ahead for further pacing maneuver just to differentiate and just to confirm the mechanism of the tachycardia, because it was 1:1 AV relation from the beginning. So with the atrial overdrive pacing, what we can be able to see that at 310 millisecond pacing cycle length, the QRS, which was RBB morphology in the present tachycardia ECG, is becoming narrower, and it is very similar to the, almost identical to the sinus ECG. And on termination or on cessation of the atrial overdrive pacing, the response what we can be able to elicit, that is AV VA response, so which is commensurating with the mechanism of the ventricular tachycardia. So with that understanding, we went ahead for mapping the substrate and not substrate, mapping the potential. And you can see here in the ablation proximal electrode, you can be able to see the P1 potential, which is coming much before the onset of the QRS. And in the ablation distal, you can see that sharp potential as P2, where we actually delivered the radio frequency energy and we were able to eliminate the tachycardia with non-inducibility. So my second case is
One second. We can have some comments from Dr. Nambudri.
Sure.
Yeah, it's an interesting case. It's a common tachycardia seen in structurally normal heart. Everyone should understand this arrhythmia, especially postgraduates when they come up, when they see a patient with the RBB with the left axis. And many times this diagnosis is missed and end up treating everything other than verapamil. And in the electrophysiology lab also, If you induce with atrial pacing, that is one of the characteristic features of this arrhythmia. In fact, Belhassen, when he described this, the classic triad, one of them is induction by atrial pacing, others being RVB with the northwest axis and response to verapamil. Good case. So,
Dr. Nambudri, can I ask you to expand a bit on which ventricular tachycardias can be induced from the atrium? And secondly, what comments can you make about inducibility of different ventricular tachyarrhythmias by a ventricular stimulation protocol? We all know that SVTs are so easily inducible. Can you talk something about inducibility of ventricular arrhythmias?
yeah, induction by a program stimulation, thereby meaning that a drive train of stimuli followed by extra stimulation of decreasing intervals. Like if you have a drive train of 600 milliseconds, then you give a coupling beat of stimuli of 400 milliseconds initially, 380, 360 in that way. If it is inducible with this program stimulation, the mechanism is of generally reentrant arrhythmias, because one of the limbs get blocked at this interval, coupling interval, and it takes us jumps to the other one. It takes a circuitous conduction, and the tachycardia comes. If you induce by a burst stimulus, burst pacing, often the arrhythmia mechanism is triggered activity. The classical example being RVOT arrhythmia. When you do with the atrial stimulation in posterior vesicular VT, again there are two limbs. The conducting impulse comes down the normally. It's actually linked to the normal conduction system. One of the limbs being posterior vesicle. It jumps when you have pace from the atrial pacing, and it initiates because it's linked to the conduction system. That is why inducibility with the atrial pacing is much common with the posterior vesicular VT compared to other tachyarrhythmias. But one should also remember that when you pace an atrial pacing with a 1-to-1 AV conduction, it is equivalent to ventricular pacing. Some of the burst, pacing in the ventricle is also similar to this. So you can have something like RVOT VT, triggered activity also coming up. Even Bundy branch reentrant VT also comes, is a reentrant tachy linked to the conduction system that can also be induced with atrial pacing. Karthikeya, anything you want to add?
No, that's excellent point. So it's actually.
Ashish.
Yes.
Hello.
Yes, yes.
Ashish,
Please.
I just wanted.
Yeah, sir, please.
Last week we saw at Science. Am I audible?
Yes,
Am I
now well.
audible?
Yes, sir.
So even last week in a teaching hospital in Mumbai, I saw two patients with vesicular VT, and the residents in cardiology were very difficult, found very difficult to diagnose, and they diagnosed SVT. So as Nambudiri said, I'll add that more important you see after termination, those T inversions, and then people undergo coronary angiogram. So the memory sign is very, very well known. But I am surprised still in today's day and age, it is misdiagnosed even by cardiologists. And then amiodarone is given, which is actually after some time it may terminate with amiodarone. Then the patients are continued on amiodarone. So for a relatively benign entity, of course, sometimes vesicular VT can be incessant and it can give rise to tachycardiomyopathy. But by and large, for a relatively benign entity, a lot of unnecessary things continue to be done, which we must keep on harping on this to make people aware of it.
Right. Karthikeya, you were saying something? Or we can move on?
Yeah, you can. I think I was just saying that the same points is covered in my last talk also, so we'll discuss it there.
I think one quick point I can make is actually in the EP lab also it is often misdiagnosed because of the narrowness of the tachycardia and somehow not looking at the His-Bundle electrogram properly. I have seen, of course, people ablating it as AVNRT and missing the proper diagnosis of, especially when it has got a 1-to-1 VA conduction, H is earlier than local ventricular electrograms, not measuring properly the HV interval.
Okay. Second case, Dr. Sarkar.
Thanks. Sorry. So my second case is a 35-year-old lady who had presented with frequent episodic palpitation, and sometimes she requires DC cardioversion outside for termination of the tachycardia. The baseline ECG is showing sinus rhythm with narrow QRS. as you can see on the left side of the panel, that sinus rhythm with narrow QRS in the baseline, and echocardiography is essentially normal. So on the right side, we can see the clinical tachycardia, which is again wide QRS regular tachycardia of LBB morphology at rate of 170 beats per minute. And as far as the P wave is concerned, I'm not very like confident to comment upon the P wave because it is not very much discernible, and morphology of QRS is typical LBB with absent Q in V5, V6 with a notch in lead 1 and AVL with left axis, and sharp intrinsic deflection with the transition at V5. So when we looked at the intracardiac electrogram during the sinus rhythm, it is showing normal AH and HV interval. And on atrial pacing, the EGM, which we can see here, that with gradual atrial pacing, the QRS is becoming wider, with surprisingly the HV is becoming shorter. And one more interesting point I should comment on, that is the reversal of the his polarity. That means the his distal is getting activated earlier in comparison to his proximal. So with that given atrial pacing and sinus rhythm intracardiac electrogram, we presume there is a presence of antidirectly conducting accessory pathway, which is having some decremental property. So we went ahead with induction of the tachycardia. Tachycardia induced at atrial burst pacing at 310 millisecond with white QRS, which is of LV morphology and quite similar to the clinical tachycardia. You can see on the right side that the tachycardia is having negative HB with tachycardia cycle length of 350 millisecond. And along with that, you can see the ablation distal, which is placed in the right ventricular apex, is having the earliest activation with regards to the his and basal RV. So we went ahead with the pacing maneuver of delivering the septal refractory PAC, which is nothing but the late PAC or premature atrial complex, which comes just with the appearance of the his signal without disturbing the septal retrograde atrial conduction. So essentially, after delivering the his refractory PAC, we can see that the PAC is able to pull the next V, the immediate next V, by 30 millisecond, and it also resets the tachycardia, which confirms the presence of the accessory pathway, which is antidirectly conducting, along with the participation of the pathway in the tachycardia circuit. So we went. Shall I continue, sir?
Yes.
Please.
So with that, we went ahead with the mapping of the our area of interest, that is along the tricuspid annulus, to find to identify the M potential or Mahem potential as it was anticipated, and we can be able to see some sharp deflection in between the atrial and ventricular EGM, which is coming with the atrial pacing, and after delivering the radiofrequency ablation, we can be able to see that disappearance of the white QRS on atrial pacing, which is one of the surrogate of successful ablation. And afterwards, we were not able to induce any tachycardia furthermore.
Yeah, Dr. Karthikeya, Dr. Nambudri, can you simplify how to diagnose and ablate this atriovascular Mahem kind of a pathway?
Karthik, you want to take up?
Yeah, so you have a wide QRS regular tachycardia, which looks like typical LBVB, and you're not able to make out any AV dissociation. So always think of atriovascular pathway related tachycardia or Mahem tachycardia, especially in a young patient with absolutely normal echocardiogram. And when we do the atrial pacing, especially from high right atrium, we see a classical finding that development of widening
Show
of
the previous
QRS,
slides, Dr. Sir.
Yeah.
widening of the QRS with LBVB morphology, which is identical to that during clinical tachycardia, but more importantly, the HV interval shows becomes shorter, or in fact becomes negative. And as elegantly shown by Dr. Rakesh, his bundle activation becomes retrograde. That is, it is normally proximal to distal, proximal first, and then in the distal electrogram, it becomes distal to proximal, suggesting that the His bundle is getting activated retrogradely, and there is an accessory pathway which gets inserted either in the ventricle or in the right bundle branch, distal part of the right bundle branch. And when we induce the tachycardia, we again find that there is a negative HV, and the retrograde atrial activation is concentric, meaning the earliest activation is occurring in the CS or the His bundle region, indicating AV nodal His-Purkinje system conduction from the ventricle to the atrium. And the earliest activation in the ventricle is in the RV apex, even earlier than the basal RV region. And when we do a maneuver, that is introduction of a PAC, we find that the ventricular signal is advanced with the same QRS morphology, indicating the presence of an accessory pathway. And then the subsequent A is also advanced, indicating resetting of the tachycardia. That tells you that not only the accessory pathway is present, but it is also participating in the circuit. And this confirms the presence of an antidromic AVRT due to presence of an atriovesicular pathway, which is slow conducting and has decremental properties. And then the ablation is guided by there are multiple ways to ablate this accessory pathway, but the best way is to look for M potential or Mahim potential. And the most common location is near in the lateral tricuspid annulus, near 3 o'clock or 4 o'clock region in the tricuspid annulus, as seen in the left anterior oblique view on fluoroscopy.
8 to 9 o'clock?
Yeah, 8 and 9 o'clock. Not sorry.
Yes,
not
yes.
8 or 9 o'clock.
Okay, let's move to your third case, Rakesh.
Sorry. So my third case is a 45-year-old lady who presented with recurrent episodic palpitation and documented white QRS tachycardia, which again required DC cardioversion outside the hospital. And you can see here the baseline ECG is completely normal QRS with sinus rhythm, whereas the clinical tachycardia ECG is having regular white QRS LVB type morphology with difficult to comment on the POA because it is probably buried within the QRS, and LVB appears to be quite typical because absent of Q in V5 and V6 with normal axis, but you can see a bit slurred onset of QRS in lead AVL and lead 2 and again in V5 and V6, but transition at level of V4. So with that, we went ahead to take the patient for the EP study because the echocardiography was essentially normal and cardiac MRI was also normal. So we thought regarding the probable etiology of the or DD about the clinical tachycardia to be either SBT with aberrancy or pre-excited tachycardia. That means it may be antidromic tachycardia mediated by Mahim, or SVT with the bystander pre-excitation, or it may be ventricular tachycardia, which is as a least possibility. So we, sorry sir, slide is not moving. So when we tried to induce a tachycardia in the lab with ISO, it was induced during the ventricular program electrical stimulation, and the same LVB type morphology, regular QRS regular tachycardia was induced, which was very similar to the clinical tachycardia with probable 1:1 without any sure comment on the AV relationship. So when we try to look at the intracardiac electrogram, I'm sorry because the HRA is not shown here, but it was 1:1 AV relation tachycardia, which is having buried his signal in his electrode, which is suggestive of negative HP tachycardia. And as a part of the his proximal, you can see sometimes the atrial electrogram is coming at the later part of the QRS. So we again went ahead with pacing maneuver. We went for atrial overdrive pacing, which is showing the AVVA response, which is commensurating with ventricular tachycardia etiology. And interestingly, during the atrial overdrive pacing also, we can see that the QRS is becoming narrower compared to the tachycardia QRS, which is also suggestive of the mechanism of ventricular tachycardia. So finally, we went for mapping the site of the origin of the VT, and we took the help of the 3D electroanatomical system, and the location where we can be able to find the earliest signal is little posterior and superior to his signal, and basically the VT was successfully terminated with delivery of the radio frequency ablation with irrigated tip catheter at 30 watts with 43 degrees Celsius with 17 ml irrigation per hour. So, sorry, per minute. And this was one of the cases of parahesian tachycardia that mimics very similar to SVT with aberrancy, but our fine or minute observation actually during the EP study revealed that it is ventricular tachycardia. So to summarize all my three cases, any negative HV tachycardia with white QRS, our approach might be 1:1 AV relation. We go for the atrial overdrive pacing, which will be good enough to find out or differentiate the mechanism of the tachycardia by and large between VT or VT and pre-excited tachycardia. So mostly during the VT, the response what will be achieved, that is AV-VA response with narrowing of the QRS during the atrial overdrive pacing. Whereas in case of antidromic AVRT or any pre-excited tachycardia, the response always will be AV-A response. And furthermore, if we are dealing with the antidromic AVRT, where the pathway is actually taking part of the circuit, there we can also apply the His refractory PAC, which or septal refractory PAC, which will be able to pull in or push the next V along with the resetting of the tachycardia. Whereas if the tachycardia is SVT with bystander pathway, so there we may be able to pull in the next V, but it will never be able to reset the tachycardia. So with that, I want to stop here, and I'm happy to take the questions.
Yeah, excellent case. Any questions from the house? Yeah, the last case was quite interesting. Left body branch block, white QRS, and but ablation from the parahesian region and suggestion of a typical left body branch like pattern during the tachycardia. One should also consider the differential diagnosis of a antidromic nodovesicular that can also behave like this, but your AVVA response had clearly excluded that. That is also that is all can result in pseudo AVVA response. So this also should be considered as a differential diagnosis. Ablation site also could be very similar. One should probably need more protocols to categorically exclude it. It's a good case, very good case.
Sure.
Can we move?
Yeah, Karthike, you can make the presentation, and Dr. Nambudri, you can inject in between in that presentation, and we can make it more lucid and useful to the postgraduates. Yeah, Karthike.
Yeah, let me just share my screen. So thank you, Dr. Ujjwal, Dr. Rakesh Dabba, and Dr. Rakesh Sarkar for presenting wonderful cases. And now my last talk for this symposium is electrophysiology in wide QRS tachycardia. Now, if the ECG were very sufficient for diagnosis, EP would not have been required for diagnosis of wide QRS tachycardia. But let's look why. What are the objectives of doing an EP study in wide QRS tachycardia? Now, it could be diagnostic, prognostic, or therapeutic. Diagnostic is to identify the mechanism. Already learned, could be SVT with bundle branch block, or pre-excited SVT or VT. And then it could be for induction of tachycardia in patients who present with syncope but no documented tachycardia, but possibility of tachycardiomyopathy, tachycardia-related syncope due to underlying structural heart disease or history of palpitations prior to syncope. Prognostic could be due to induction of VT or VF as a part of risk stratification for sudden cardiac death that is done in multiple conditions. It was previously done in coronary artery disease, still done in patients who have fairly normal or 35 to 40% ejection fraction, but have non-sustained VT and syncope, or in certain other diseases like Brugada syndrome, where it is controversial. Then finally, it could be as a therapeutic as a guide to ablation and to identify the targets of ablation of wide QRS tachycardia. Some of the examples could be, if it is an idiopathic monomorphic VT, we look for site of earliest activation in the ventricles. If it is a pre-excited tachycardia, we look for the atrial and ventricular insertion sites of the accessory pathway. And if it is SVT with bundle branch block, again, it depends on the mechanism of the SVT. For example, slow pathway ablation in AVNRT, site of earliest activation in focal atrial tachycardia, or looking at accessory pathway potentials in AVRTs. And especially in certain situations like polymorphic VT, where VT is initiated by a monomorphic PVC, identifying the earliest site of activation of PVCs and initiating the VT and ablating them can actually cure this patient, though there will always be some risk of recurrence. And this is highly rewarding procedure in such patients where these polymorphic VT can be actually life-threatening. So before I go to the EP study, I'll just let you know that the advantage of doing an EP study is, now we have seen in previous examples of wide QRS tachycardia as shown by our fellows, that many of the times, in fact, most of the times, if there is no AV dissociation, it is almost impossible to be sure about the P waves during a wide QRS tachycardia, because the P waves get buried in the QRS or maybe may not be seen at all on the surface ECG, even to a very experienced ECG reader. And you can never be sure where the P wave is lying during a wide QRS tachycardia, especially if the AV dissociation is not apparent. Secondly, the surface ECG, though, is a very good technique to diagnose these arrhythmias. One of the limitations of a surface ECG is that you cannot see the His bundle, which is very well seen during the electrophysiology study, and differentiates or classifies the PR interval into AH and HV intervals, and also gives you a lot of information about the underlying cause for widening of the QRS, whether it is aberrancy, whether it is VT, or whether it is pre-excitation. So when we start doing an EP study in a patient who had come with wide QRS tachycardia, we look for certain observations during sinus rhythm. One of them being, if the HV is shorter and there is pre-excitation present during sinus rhythm, or not very apparent during sinus rhythm, but can be brought about by pacing the atria a little faster, it suggests that the underlying mechanism of wide QRS tachycardia may be SVT, and the absence of pre-excitation during sinus rhythm and atrial pacing almost always excludes a pre-excited SVT as a mechanism of wide QRS tachycardia. Then induction of tachycardia, Dr. Namudri talked about a bit. Again, mode of induction, whether induced by ventricular pacing or atrial pacing, does not help in distinguishing between SVT and VT, since both atrial and ventricular stimulation can induce both SVT and VT. typically we all understand that SVT can be very easily induced with atrial pacing, but there are certain SVTs which may be inducible by ventricular pacing, and these include AVRTs due to presence of accessory pathway and atypical AVNRT where the retrograde conduction is over a fast pathway, slow pathway. Then there are certain VTs that can be induced by atrial pace stimulation, and these include all the VTs which are including recruiting the His-Purkinje system, like fascicular VT and bundle branch reentry VT or interfascicular VT. And there are certain other VTs which are due to triggered activity, as Dr. Namudri said. When we do atrial pacing, it's like burst ventricular pacing for that patient. And then VTs like RVOT VT, which are due to triggered activity, can also sometimes be induced by atrial pacing. So this is an example. As this patient, you may see that the ECG may look apparently normal, and but there may be just a very subtle pre-excitation. But when we do an EP study, we put our His bundle catheter, we find that the HV interval is actually very short or even negative. You see the HV interval, we need to measure it from the onset of the His bundle signal, His bundle electrogram, to the onset of ventricular activity wherever it is seen the earliest. It may be surface ECG or maybe any intracardiac electrogram. And in this example, where the earliest ventricular activation is seen in the distal coronary sinus electrogram due to presence of a left-sided, left lateral accessory pathway, and see that the HV interval is almost zero, indicating that there is pre-excitation present even during sinus rhythm, which was not very well apparent in the surface ECG. Then looking at once we induce the tachycardia, look at the QRS morphology, whether it is similar to the baseline, and if that means that is SVT. One of the questions was asked during the chat that is there any VT that can look like similar to sinus rhythm, and that the answer is a bundle branch reentry VT and interfascicular reentry VT, which may have identical morphology that during sinus rhythm. And then we look at whether the QRS morphology of the tachycardia, same thing that we discussed during our ECG presentation, is compatible with typical LVVB, again suggests SVT. Then one of the most important things that we look during an EP study is look at the HV interval. Now, if the HV interval is negative during tachycardia, it indicates that it is either VT or a pre-excited SVT. A positive HV, which is smaller than HV during sinus rhythm, has the same significance as a negative HV, whereas a positive HV, which is same or more than during sinus rhythm, indicates SVT with aberrancy. And the only exception is bundle branch reentry VT, where the HV interval may be longer than that during sinus rhythm, but it is still a VT. So this is a very interesting case, very good example, and very good tracings to show the difference between SVT and VT. Now, in the initial part of the tracing, the first 4 beats, we see that we are pacing the atria through the catheter in the coronary sinus, and we see that the HV interval is normal. You can see with these red markings, the HV interval is normal, but the QRS is wide with a positive QRS in lead V1, indicating that there is wide that there is right bundle branch block pattern or right bundle branch block with the normal HV during atrial pacing. But as the pacing is stopped, you see that the QRS remained wide, though the morphological pattern changes. But most importantly, a thing that need to recognize, as was also pointed by Dr. Nambudri, that you look at the HV interval. Now you see that the H and V are occurring nearly at the same time, and the HV interval is actually 0, indicating that this is a ventricular tachycardia. This cannot be anything but VT, because during atrial pacing, there was no pre-excitation, but as the tachycardia occurs, the HV becomes 0. So the only possible explanation is ventricular tachycardia. And one, as an electrophysiologist or even a cardiologist, one should learn to recognize the subtle changes in the QRS morphology. You can see this may, if you just look at V1, you may be fooled to think that this is the same morphology, but look at lead 2, the axis has changed as also in lead V1. But and there is 1-to-1 AV conduction during the tachycardia, which may indicate to you that it is AV and RT. And because of the young age of the patient, the ventricular retrograde conduction to the atrium is also very rapid, and this VT conducts 1-to-1 to the atria with a very short VA interval, but a short or a 0 HV interval indicates that it is VT. And if you look at the ECG, you see the first 2 beats are sinus rhythm beats, again with right bundle branch block and inferior axis. But the next few beats, again with atrial pacing, show a similar QRS morphology. But once the tachycardia is induced, you see the morphology changes, though it is still right bundle branch block pattern, but the axis is now left axis, especially the right superior or northwest axis, and you see a small R enlarged there in lead V6, again indicating that it is VT and not SVT. Another example where you see again during the tachycardia, it is LBBB pattern, and again there is 1-to-1 relationship. Again, the differential could be VT, SVT with bundle branch block or pre-excited SVT. But once you look at his bundle electrogram, you see that the HV is 50 milliseconds, which is same as during sinus rhythm. So this confirms that it is SVT with bundle branch block. Only exception could be that it may be a bundle branch re-entry VT. But most likely it is a orthodromic reciprocating tachycardia with bundle branch block, since his atrial activation is occurring somewhere in the ST segment. The most common diagnosis here would be AVRT due to an accessory pathway. Now, after that, we look at his bundle and right bundle potential relationship. Now, normally during sinus rhythm, as was shown in the first case by Dr. Sarkar, his bundle activation normally occurs from proximal to distal, and then the right bundle gets activated. And if there is a change in activation of these electrograms, then it is not a supraventricular rhythm. That is for sure. So any alteration, if it is right bundle, his bundle, and then ventricular, or right ventricle, right bundle, ventricle, and then his bundle, or ventricular first and then right bundle and his bundle, that means there is a change in the activation pattern of his bundle and right bundle potentials, then it is not supraventricular tachycardia. It is either antidromic AVRT or which could be either myocardial or bundle branch reentry VT. Another useful feature that we look during an EP study is a vowel. Now, vowel means slight irregularity in the tachycardia cycle length, is actually a friend of electrophysiologists, because that helps you to find that what variation in which interval is preceding the variation in another interval. For example, if the variation in VV interval is dictated and preceded by similar variations in AA or HH interval, it tells you that it is not VT. It could be SVT with aberrancy, and rarely it could be bundle branch reentry VT, but cannot be a myocardial VT. Similarly, variations in VV interval that predict subsequent HH interval, that tells you that it is not SVT, but could be either myocardial VT or pre-excited ventricular tachycardia. So this is a classical example. You see that it's a wide QRS tachycardia, relatively slow, and with a positive QRS in lead V1 indicating right bundle branch block pattern. And you see that in the HRA tracing, there is 1-to-1 relationship of this tachycardia, but you cannot see any his deflection. In fact, in this case, his was not seen at all. It was not possible to localize the his signal at all, and it was a lot of confusion whether it is SVT or with aberrancy or VT. But you look that the QRS is, or RR interval is varying a bit. And if you look carefully, the RR interval, changes in RR interval precede the changes in VV interval. And so this rules out a supraventricular tachycardia or atrial tachycardia, and it excludes atrial tachycardia and tells you that this is a ventricular tachycardia. And next thing, the most important thing and the most easiest thing to look for is AV relationship. Now, if you have more ventricular complexes than atrial complexes, For all practical purposes, this is ventricular tachycardia. There could be other rare diagnoses like AVNRT or junctional tachycardia with VA block, or AVRT using a nodovascular nodoventricular accessory pathway. But for all practical purposes, for most common things, it is going to be ventricular tachycardia. On the other hand, if the atrial complexes are more than ventricular complexes, then it is most likely a supraventricular tachycardia, with atrial tachyarrhythmias being the most common diagnosis, either atrial tachycardia, atrial flutter, or atrial fibrillation. But rarely an AVNRT may exist with 2-to-1 AV block. And but always remember that there are certain times coexisting dual tachycardia, that is atrial tachycardia as well as ventricular tachycardia may coexist, and but for sure it excludes AVRT due to typical atrioventricular accessory pathway. But the most challenging one becomes when the number of ventricular complexes is same as the number of atrial complexes, meaning there is 1-to-1 AV relationship. Then it could be either VT or SVT, and then we have to look at the other things like the HV interval and do certain pacing maneuvers to look for whether it is SVT, VT, or pre-excited SVT. So let's look at a few examples. Here you see that is an induced tachycardia, and you find that the number of QRS complexes is more than the number of atrial complexes. And for every 2 QRS complexes, there is 1 atrial complex, meaning that this is VT with 2-to-1 VA conduction. Another example, in contrast to the previous example, here the RR interval is regular, but the AA interval is not regular, but the number of QRS complexes is more than the number of atrial complexes. So always think of Wenckebach VA conduction in this scenario where you have varying PP interval with regular RR interval, and the atrial activation is not due to sinus rhythm. So you have VA Wenckebach in a 3-to-2 pattern. Again, not VA dissociation, but more V's than A's, suggesting you a diagnosis of ventricular tachycardia with 3-to-2 VA conduction. Another example, you see a wide QRS tachycardia with RBBB pattern and inferior axis, negative QRS in lead 1 and AVL, suggesting left to right ventricular activation. Now, difficult to make out whether it is VT, pre-excited SVT, or SVT with aberrancy. But if you just look at a couple of leads, for example, lead AVR, you find that the pattern actually looks like that it may actually be atrial flutter. And then you look carefully at other leads like AVL, you do find that there is some complexes which look like P waves in the middle of the RR intervals. And so this could be atrial flutter. And when we do an AP study, you find that this is actually atrial flutter. There are 2 atrial signals for every QRS complex. But interestingly, what you see here that though the atrial cycle length is double that of the ventricular cycle length, or half that of the ventricular cycle length, you see that his signal is actually buried in the ventricular signal in his electrogram, meaning it's a short HV. So there is atrial flutter, but there is a 2-to-1 conduction, but the conduction is occurring over the accessory pathway that is resulting in a negative HV interval. And that is also confirmed that if you look at the atrial activation pattern, it is proximal to distal in the coronary sinus, but the ventricular activation pattern, if you look carefully, it is occurring first in the distal CS, and then the basal CS and the RV are activating late, again because the left ventricle is getting activated earlier due to pre-excitation due to left lateral accessory pathway. So this is a tracing of atrial flutter with 2-to-1 conduction over left lateral accessory pathway. Now, if your diagnosis is still not clear, you may need to do certain pacing maneuvers. And in contrast to narrow QRS tachycardia, where ventricular pacing maneuvers are more...
রেডি হ আমরা 12:30টায় বেরোবো, 11:45, 12:30 পৌনে 1। হ্যাঁ, তুই চান টান করে নে।
can you please mute yourself? Thank you. So in contrast to narrow QRS tachycardias where ventricular pacing maneuvers are most useful, in wide QRS tachycardias, atrial pacing maneuvers are more useful. And the most useful maneuvers are a couple of these. One is an atrial extra stimulus and the atrial pacing, burst atrial pacing during wide QRS tachycardia. Now, during atrial extra stimulus, if the ventricular signal is advanced, it proves the presence of an antegrade conducting accessory pathway. And if it advances with the same QRS morphology, that tells you that wide QRS tachycardia is pre-excited SVT and excludes VT. And if the atrial extra stimulus changes the ventricular activation, either advances, delays, or terminates the tachycardia, it is diagnostic of antidromic AVRT using decremental accessory pathway. Second maneuver is atrial pacing maneuvers. I'll not go into the details of this. This has been shown in a few examples earlier, but since our target audience is cardiologists and physicians and DM cardiology students, I'll not go into the details because it is a little complex and more for the electrophysiologists. But just to understand a few, we'll show a few maneuvers that during a wide QRS tachycardia, if we do atrial pacing and the ventricular rate is accelerated to the atrial pacing rate and the morphology changes and becomes narrow as during sinus rhythm, that tells you that the wide QRS tachycardia is ventricular tachycardia. The other possibility is in a ventricular tachycardia is that the atrial pacing at a faster rate than the tachycardia cycle length will not change the ventricular rate, and so you have induced AV dissociation, again telling you that the tachycardia in question is a ventricular tachycardia. On the other hand, if we pace the atria and the ventricular rate gets advanced and the QRS morphology remains the same as during the tachycardia, then it is a SVT or rarely bundle branch reentry VT and excludes myocardial VT. So this is an example. You have an incessant wide QRS tachycardia with RBBV morphology and left axis of the QRS in the frontal plane. And when you do an EP study, you find that there is 1-to-1 AV conduction, and the His signal is not being seen here. Probably it is buried inside the QRS or ventricular signal. But when you do atrial pacing, you find that the QRS becomes normal and narrow. The same tracing that was shown by Dr. Rakesh. You find that during atrial pacing, the QRS becomes normal and narrow. This confirms that the tachycardia in question is a ventricular tachycardia. And this occurs because of fusion and capture through the AV node His-Purkinje system, and it is diagnostic of ventricular tachycardia. Another example, you have a relatively slow wide QRS tachycardia. The referring doctor was not convinced that it is VT, although the patient had a clinical history of past MI with severe LV dysfunction, and the QRS morphology is not like that of a typical RBVV with a small r and large s in V6, indicating that it is ventricular tachycardia, but a sinus rhythm ECG was not available because of inconsistent nature of this tachycardia. Hence, an EP study for diagnostic purpose was performed. And as you see, as soon as we pace the atria, the QRS becomes narrow. And once the pacing is stopped, you have A, V, V, and A response, as was also shown by Dr. Sarkar, indicating that the tachycardia in question is ventricular tachycardia. A few more examples. Here, you again have a wide QRS tachycardia with left bundle branch block morphology, 1-to-1 AV relationship, and the HV interval is 50 milliseconds, which is same as during sinus rhythm, and a short septal V interval, indicating a diagnosis of AV and RT with left bundle branch aberrancy. So just to summarize, EP study in wide QRS tachycardia, we look for baseline features, which is the HV interval. If it is short or negative, tells you that there is pre-excitation. Then we look at the tachycardia features, look at the AV relationship, whether there is AV dissociation or V more than A or V less than A or V is equal to A. And then next, again, we look at the HV interval during tachycardia, whether it is negative, short, or same as baseline or prolonged. Then look at the QRS morphology and look at vowel in the cycle length to see which intervals are preceding which intervals. And if the diagnosis is still not clear, we can do certain atrial pacing maneuvers like atrial extra stimulus, looking for advancement or delay in QRS with any change in QRS morphology. And then atrial pacing to look for entrainment, and fast atrial pacing to reveal any AV dissociation. Finally, ventricular pacing may be useful in very rare varieties of wide QRS tachycardias, like nodoventricular, nodovesicular tachycardias. And with that, I think I'll end here and we'll be happy for any comments, discussions, and questions.
So, Karthika, you can project that last slide. And if the postgraduates want, they can take a snapshot of it and we can ask Dr. Nambudri to offer some discrete comments on.
Yeah, I think it was a great presentation, Karthikeya, and great examples as well. As we are short of time, we can have a couple of comments from the house. Any questions from the postgraduate we can take up?
Yes, so we don't have just now many things on the chat box. I think you can take the initiative and
yeah. I think primarily for the postgraduates, it's important to look at the ECG at baseline and during tachycardia and apply all the principles that we learned in the initial part of the session in differential diagnosis of wide complex tachycardia. That everyone would agree, even if the patient is being taken for electrophysiology study. Then in the EP lab, also you look at whether this patient has got a structural heart disease, whether it could be VT in that aspect, granulomatous myocarditis, and apparently normal heart we have discussed. Is there any ECG features at baseline or during tachycardia that would suggest some atypical nature, like we have seen those epsilon waves, delayed activation, intrinsic cord activation, T inversions, and subtle pre-excitation? Those features one should look for. In the EP lab, often the diagnosis of VT differentiation from antidromic tachycardia and aberrancy is simple. As Dr. Karthikeya pointed out, VA conduction happens only in 40% of cases. VA dissociation comes up. HV interval one should always look for. HV interval is the most important thing one should look for in the differential diagnosis of wide complex tachycardia. And then one would need some atrial pacing protocols. If you have wide complex tachycardia, go with atrial protocols. If you have a narrow complex tachycardia, go with ventricular protocols initially. With these simple steps, one can make a differential. That is essentially what Dr. Karthikeya showed here. HV interval, AV relationship, HV interval, whether it's negative, short, or same. Then the morphology of the QRS, atrial pacing, and if needed, ventricular pacing as well. It's quite simple in that aspect, in the approach. Dr. Ashish, any?
Sure. Thanks, Dr. Nambudri. Actually, a great presentation from the whole team of Dr. Bhargava, and very succinct comments from Dr. Nambudri and Dr. Venkat. To the postgraduate, I must say that this has been a comprehensive class, so to say, some delay being technical in the initial 15 minutes, but it needed to be that long because wide QRS tachycardia does take a little teaching and discussion. It might be very easy for you to pick up online the ECG features of differentiation, and most of the EP study are highlighted, especially the HV interval. Some of the atrial pacing and ventricular pacing maneuvers might need a little bit of reading again from you. So for those who attended the session and also convey to your friends who could not attend today but were interested in this class, that all these sessions of the IHRS teaching program are available on the IHRS website. You don't have to be IHRS member to see them. Thanks to our secretary, Dr. Vanita Arora, all these sessions are available, including the today's. So sometimes you need to go through them again to get a good handle of what has been discussed. A good number of you have attended today. Of course, there are many more whom we would like to attend. But anyway, my thanks to Dr. Bhargava and his team. It takes effort to weave such a class and present in a good way that is very exemplary. I must also thank Dr. Nagarajan and Dr. Nambudri, who took out time on the Sunday morning to add their flavor to this whole teaching program. I think in the interest of time, we have overstepped considerably. So I will conclude today's wide QRS Tachycardia session. Hope you benefited. And next month, that is 7th August, we'll once again join with more willing IHRS faculty who would really like to communicate with the postgraduates and bring something more on table. So we'll announce the details later. I think we'll close the program here. Once again, thanks to the team of Dr. Bhargava for making wonderful presentations. Thanks, Kartikeya. Thanks, Dr. Nambudri. Thanks, Dr. Nagaraj.
Thanks, Dr. Ashish, and the entire team, Rakesh, and Ujjwal, and Dr. Venkat and Dr. Nambudri.
Thank you very much.
Thank you.
Thanks. Bye. Till the next month.
Thank you.